Good afternoon. Today I'll be presenting a Purtscher-like retinopathy in a case of acute pancreatitis. A 14-year-old girl came with the complaints of abdominal pain, recurrent episodes on and off for the past 5 years, which was dull aching, increasing in severity for the past 3 days, vomiting for the past 2 days, which is non-projectile, associated with diminution of vision in both the eyes for the past 1 day. Even though the patient had abdominal pain on and off for the past 5 years, this episode was accompanied with a diminution of vision for the past 1 day, which was sudden in onset, painless, and progressive in nature. Past history: patient gives a known case of pancreatitis, had recurrent episodes over 1 year back. Documents showed that MRCP done in the previous episodes revealed pancreatic divisium with pancreatitis and features suggestive of the same. Personal history: consumes mixed diet, normal bowel and bladder habits, and normal sleep pattern. General examination of the patient revealed icterus, otherwise pulse rate and blood pressure was normal. Systemic examination: per abdominal examination showed a mild tenderness noted in the epigastric region, no guarding. Cardiovascular system, respiratory system and CNS was not remarkable. Ocular examination of the right eye showed a best corrected visual acuity of 1/60 and left eye showed 3/60. Otherwise, ocular examination was normal. Fundus examination in both the eyes showed disc pink in color, vertically oval, and elevation of the disc over the temporal edge, and vessels arising from the center of the disc branching dichotomously, and background retina in both the eyes showed multiple cottonwool spots surrounding the disc. Routine investigations were done, and the patient revealed that the serum amylase and lipase found to be elevated, suggestive of acute and chronic pancreatitis. And OCT showed elevation of the perifoveolar region. A noted edema has been noted in the inner retinal layers between the disc and the macula, which was more pronounced in the right eye than in the left eye. Patient was subjected to a routine USG abdomen followed by MR cholangiopancreatography, for which the features were suggestive of the same acute pancreatitis. Treatment was started by the surgical gastroenterologist for acute pancreatitis, and patient was also started on injection IV methylprednisolone 35 mg per kg per day for 3 days, followed by tablet prednisolone for 11 days, nepafinac eye drops and tablet acetazolamide. The patient's visual acuity was routinely checked up, and on the day 12 of steroids, the patient's visual acuity improved in the right eye to 612 partial and in the left eye to 612. A fundus re-evaluation showed resolution of the disc edema and also the clearance of the cottonwool spots and the edema in both the eyes. Discussion: Purtscher retinopathy is described as a chorea retinopathy associated with any indirect trauma or non-ocular injury, whereas any typical retinal findings occurring in the absence of trauma, it is referred to as Purtscher-like retinopathy. The most common clinical symptom is always diminished visual acuity. The most frequently encountered fundoscopic signs were cottonwool spots and noted in 93% of the cases. Diagnosis is made if at least 3 out of 5 criteria are present, namely Purtscher flecken, retinal hemorrhages, cottonwool spots confined to the posterior pole, probable explanatory etiology, and complementary investigations compatible with diagnosis. Possible pathogenesis: the elevated pancreatic and lipases will stimulate the complementary system, and which causes leukocyte aggregations, which can cause an emboli and microvascular infarct of the retinal nerve fiber layer. Treatment literature also supports a high dose intravenous steroids in improving the visual acuity, which prevents the granulocyte aggregation and complement activation and partial recovery of the neuronal fibers. These are my references. Thank you. Fundus picture on the day of presentation, and the fundus picture a repeat OCT has been taken, sir. This is the fundus picture, sir.
So I think in pancreatitis, the basic problem I think is what we call leucoembolism or fat embolism. That causes the arterial block in
Yes,
such
sir.
patients.
Yes, sir.
And not a very common disease, honestly speaking. We have seen a lot of pancreatitis, but I think you treat it with IV methylprednisolone.
Yes, sir.
But there have been reports about intravitreal steroids also. Have you seen that?
Yes, sir. Certain reports suggest of intravitreal steroids. And also there was one of the case report where a patient with acute pancreatitis presented with both acute renal cortical necrosis and Purtscher like retinopathy, and visual acuity and the inflammation improved with IV
But
methylprednisolone
role
as
is
well.
quite controversial. You see, if you see literature, role is very, very controversial. But I agree with you that we have to, be on the defensive side primarily to save the
Visual acuity.
yeah. And most of the case reports case reports do say IVMP does help, but there have been reports about intravitreal drug therapy also. Good, good contribution.
Role of acetazolamide?
Because the patient had edema, in order to prevent any further edema in the macular region, we were started on acetazolamide, ma'am, because on the second day and the third day the macular reflex was dull and we noted some edema in the macular region. That's why we start.
Secondary to the disease person.
Yeah.
Actually, there is a lot of over usage of acetazolamide or Dorzox or such things. Aim is to pump the have the more pumping action of RPE. But
We should be careful in intestinal conditions like pancreatitis.
good case.
Thank you.
I think the purpose of these case presentations is very well received in midterm conferences, because when we started midterm conference, we thought we will not have any national symposiums